Hello, I'm Dr. Kimberly Ford. On behalf of CMEO Outfitters, I'd like to welcome you and thank you for joining us for part two of a three-part CMEO Pharmacist Central educational series entitled Patients with Hepatitis B, Medical Comorbidities that can impact treatment and prompt the provider to switch. The CMEO Pharmacist Central series is supported by an educational grant from Gilead Sciences. As I mentioned, I'm Kimberly Ford. I'm a hepatologist, associate professor of medicine in the section of hepatology, Department of Medicine at Temple University Hospital at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. I'm very happy to welcome Dr. Christina Madison to the program. Dr. Madison is the founder and CEO of the Public Health Pharmacist. She's also an associate professor of pharmacy practice at Roseman University of Health Science College of Pharmacy in Las Vegas, Nevada. Welcome, Christina.
Thank you so much for having me. I'm very excited to be giving this presentation with you today, Dr. Ford.
Awesome. So let's begin with our learning objective, which is to partner with patients with hepatitis B virus and their healthcare professionals to support therapeutic decision-making in the presence of renal and bone comorbidities. To review the goals of treatment, they include to impact the natural history of hepatitis B virus, firstly by suppressing hepatitis B viral replication, reducing progression to cirrhosis, reducing other liver-related complications such as the development of hepatocellular carcinoma and need for liver transplantation, and of course, thereby impacting long-term survival. The schematic to the right outlines some of the laboratory markers which are used to determine treatment success, including an undetectable hepatitis B DNA, and of course, loss of hepatitis B E antigen, and the gold standard, which is really loss of surface antigen, which is labeled seroconversion. So pharmacists really play a pivotal role on the collaborative healthcare team in helping to achieve both these short and long-term treatment goals. So I think at this juncture, it would be wonderful to have Christina do a brief refresher on hepatitis B screening and vaccination schedules. We're going to start first by reviewing the U.S. Preventive Services Task Force, or USPSTF recommendations.
As you mentioned before, obviously we want to make sure that the most appropriate individuals are being screened for hepatitis B virus. So currently the USPSTF recommends screening for hepatitis B viral infection in adolescents and adults at increased risk of infection. So this currently includes any persons born in countries or regions with a high prevalence of infection, which is defined as greater than or equal to 2%, such as Asia, Africa, Pacific Islands, and parts of South America. U.S.-born persons not vaccinated as infants whose parents were born in regions with very high prevalence, which is defined as greater than or equal to 8%, as well as those who are HIV positive, those who are currently engaging in injection drug use, individuals who are men who have sex with men, and household contacts of sexual partners of persons with hepatitis B viral infection. Additional at-risk populations that the USPSTF also recommends should be screened and are part of our CDC and ACIP guidance include individuals requiring immunosuppressive therapy, anyone with end-stage renal disease, including those receiving hemodialysis, individuals with elevated AST and ALT, infants born to a hepatitis B surface antigen positive mother, donors of blood, plasma, organ, or tissue, or semen, and then those persons who are the source of blood or bodily fluids, inmates in correctional facilities, persons with hepatitis C viral infection, and last but not least, persons with multiple sex partners or histories of sexually transmitted infections.
So Dr. Madison, in addition to screening, hepatitis B vaccination should be a primary objective for individuals at risk. Who are at-risk individuals that pharmacists may want to open up a discussion about vaccination status?
So that's an excellent question, Dr. Ford. And as you can see, our ACIP recommendations include those adults who may be needed to get additional screening or more vaccinations for hepatitis B vaccine. So that includes those high-risk individuals that I just outlined previously. So those who may come in contact with a pharmacist and may need additional vaccination are those who have a sex partner who has hepatitis B surface antigen positive, those who have sexually active persons not in a long-term mutually monogamous relationship, persons seeking evaluation or treatment for a sexually transmitted infection, and again, that MSM population that we spoke about earlier, or our men who have sex with men. So that really encompasses those who have a sexual risk or risk of exposure because of behavior. And then those who have a history of current or recent injection drug use, we also want to make sure are up to date with their vaccination. And this also includes any household contacts, residents and staff of facilities for developmentally disabled persons, healthcare public safety personnel at risk for an exposure to blood or infectious contaminated bodily fluids, individuals who are receiving hemodialysis and pre-dialysis, including peritoneal dialysis and at-home dialysis patients. And then also, this is a big one because we see so many of our patients with diabetes. Any individual who has diabetes mellitus who is less than 60 or over the age of 60 at the discretion of the treating clinician. And so again, we are really trying to focus on individuals who have that risk and could greatly benefit from vaccination. So we also want to make sure that we encompass a few other individuals who may also benefit from vaccinations. And this also includes our ACIP recommendations for international travelers to countries with that high prevalence or intermediate prevalence of hepatitis B virus, which we mentioned earlier. So Asia, South America, and then persons with hepatitis C viral infection, those with chronic liver disease, including but not limited to cirrhosis, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, as well as those who have AST or ALT that's greater than 2 times the upper limit of normal. We also have those individuals that are currently having a positive HIV status, individuals who are incarcerated, who may be engaging in, say, illegal tattooing or engaging in injection drug use, and then other persons seeking protection from hepatitis B viral infection, even without an acknowledged or specific risk. And I think that's super important to mention, that self-identified risk is all we need from a patient. If they are stating that they want protection for hepatitis B viral infection, we need to be providing vaccination.
So, Dr. Madison, let's focus our vaccination discussion on adults. What are the available vaccines and their respective schedules?
Absolutely. So we are very lucky that we have multiple vaccine presentations to choose from. They include our Energix B, which is recommended for all ages, including infants. We have our Heplisav B, which is only recommended in adults 18 years and older, not recommended for use in pregnant women. We also have Recombavax HB, which is also indicated for all ages. We also have some combination products which are very useful that protect against both hepatitis A and B. So we've got the Twinrix bivalent inactivated hepatitis A and B vaccination, which can be utilized. It's also available at an accelerated schedule for individuals who may be engaging in international travel. So you can vaccinate them at 0 and 7 days, and then 21 to 30 days, and then a booster at 1 year. So let's go ahead and talk in a little bit more detail about this vaccine schedule. So let's go ahead and start with our single antigen hepatitis B vaccines, which include Heplisav B, Energix B, and Recombavax HB. So as you can see here, our first vaccine that's available for year 18 and up is our Heplisav B, and we can vaccinate you with 2 doses 4 weeks apart, which is a great benefit to this vaccination. We also have Energix B, which can be provided at 0, 1 month, and then at 6 months to complete the series. And then if you have someone who is currently receiving hemodialysis, it's this schedule here where we would add an additional dose at 2 months and then again at 6 months. So a total of 4 vaccinations for complete series. And then our Recombavax HB, again, very similar schedule as our Energix B, which is going to be 0 at 1 month, and then the final dose at 6 months. And then last but not least is our Twinrix, which we talked about earlier. So 0, 1 month, and 6 months. Or you can do that accelerated schedule that we discussed earlier, which would be 0, 7 days, and then 21 to 30 days with a booster dose at 1 year.
Great. Dr. Madison, let's switch gears just a bit to talk about hepatitis B treatment, and in particular, who and when to initiate treatment. While the American Association for the Study of Liver Diseases, the AASLD, has detailed guidelines for the management of chronic hepatitis B infection, management or treatment of hepatitis B does not have to be driven by specialists, especially when such expertise may not be readily available. So the guidance, or the simplified approach that's presented on this slide, comes out of work from the Hepatitis B Primary Care Work Group, which is a multidisciplinary panel of national experts. And they published this simplified guidance specifically for primary care providers. So this chart comes from the guidance document that was published in February of 2020. And I think that there are some key things to point out. So you need some key pieces of information about your patient. So the first is whether they have a history of cirrhosis. That could be established by biopsy if they've had that in the past, by abdominal imaging, or by other non-invasive assessments of hepatic fibrosis. So that's the first piece of information to know. The subsequent 2 pieces of information to know are the hepatitis B DNA as well as the ALT. So we're going to talk a little bit about what we now consider a normal ALT in the next slide. But I do want to point out the fact that the ALT range is probably going to be a little different from what providers are used to. We'll talk about that in a minute. The AASLD guidance also requires that there's an assessment of hepatitis B antigen as well as antibody. That is not required here in this simplified guidance. So if we take the first row of the chart here, so this applies to all patients with chronic hepatitis B infection who have a history of cirrhosis. They can have any hepatitis B DNA level and any ALT. So that means a normal ALT or an abnormal ALT. And the guidance here is to treat with antiviral medications. In addition, there's going to be monitoring of the hepatitis B DNA and the ALT every 6 months. And for routine cirrhosis care, such as the performance of an upper endoscopy for screening of varices, and for hepatocellular carcinoma surveillance, individuals should be following with either a gastroenterologist or hepatologist. Additionally, all patients with decompensated cirrhosis should really be following with a hepatologist and a determination made as to whether liver transplantation evaluation is required. Going on to the next row of our chart here, this refers to the patient who is non-cirrhotic, who has a high hepatitis B DNA level, and they have an elevated ALT. Again, we'll talk about what an elevated ALT is. And the recommendation, again, is to institute therapy with antiviral medications. Here we can see this is the patient with elevated hepatitis B DNA and a normal ALT, and that patient will be monitored every 6 months with a hepatitis B DNA and the ALT, and a fibrosis assessment to be conducted every 2 to 3 years. In the last row of this guidance, we see here people with a low hepatitis B DNA. so less than or equal to 2,000 international units. If they have an elevated ALT, the thought is really that we should be ruling out other forms of liver injury. And if the ALT is normal, that we should be following patients serially. So I think that this is a great simplified approach. It really helps to break things down, and it really means that some of the treatment of chronic hepatitis B infection does not have to occur in the setting of having a specialist available.
So what are normal ALT values in healthy adults? So, Kim, the simplified approach to treatment as well as the AASLD guidelines refer to ALT levels as 2 times the upper limit of normal. Is there an easier way to remember what that really translates to?
Sure. On this slide, we see a great representation of this. And I want to give the viewers a little contextual background regarding how we now determine what is a normal ALT. So when I was training, we would actually look at the upper limit of normal range for the particular laboratory that determined the ALT value. And what we've come to appreciate is that normal reference population perhaps included patients that had underlying chronic liver diseases that weren't appreciated. And in fact, there are also linear relationships between ALT and body mass index and ALT and gender. So how we've come to appreciate what's a normal ALT now is a bit more refined. So we don't just use an underlying population of who we perceive to be healthy individuals. Now there's also a determination of whether there's perhaps underlying liver disease that's not appreciated in determining that healthy cohort. And so many studies have determined that a normal ALT for a woman is 19 and a normal ALT for a man is 30, which is certainly much lower than, when I was training. I think a good rule of thumb is that anything over 25 for women and anything over 35 for men is considered abnormal. The other thing that I want to point out is that patients with a normal ALT can certainly have significant underlying liver disease. We have seen this in our experience with hepatitis C infection, of course, chronic hepatitis B infection, and other chronic liver disease processes such as hemochromatosis. So you shouldn't be fooled into thinking that a normal ALT means that there's no underlying liver disease. Lastly, we also understand now that an elevated ALT is associated with adverse liver outcomes. So really determining what that normal ALT is and treating to that is pretty important.
So what are some of our treatment options for these types of patients, Dr. Ford?
So the key treatment options include the highly potent antiviral therapies that we see here displayed on this slide. So we have entecavir, we have tenofovir diisopropyl fumarate, which I will call TDF intermittently throughout the talk. And there is also tenofovir alafenamide, which we call TAF or TAF. Certainly, interferon is one of the medications that can be utilized to treat chronic hepatitis B infection. That tends to be in younger patients who want a finite duration of therapy. They're not interested in prolonged or lifelong therapy. And certainly, there are adverse events that can be associated with interferon use. So we're not going to talk about that specifically today, but certainly in clinical practice, these are the 3 agents that are utilized. Entecavir is started at a standard dose of 0.5 milligrams once daily. For those patients with decompensated liver disease, 1 milligram once daily is the recommended dose. And entecavir can be taken 2 hours before or after food. There are certain side effects associated with entecavir. These include fatigue, dizziness, nausea, headache, and are reported in over 3% of those patients on this medication. A dose adjustment is required if there is underlying renal dysfunction. and also for patients in whom lactic acidosis could be a concern, that should be evaluated promptly. For the TDF preparation of tenofovir, it's 300 milligrams once daily by mouth. This can be taken without regard to food. Again, we see some GI side effects, nausea reported in 9% of patients. Post-marketing surveillance has identified some adverse events associated with therapy. They include nephropathy, Fanconi syndrome, osteomalacia, and of course lactic acidosis, which I had mentioned with entecavir. There's also a dose adjustment here in the setting of renal dysfunction. And it's important to monitor for renal health and bone health while patients are on the TDF preparation of tenofovir. And then lastly, the TAF preparation is 25 milligrams by mouth once daily, and that's taken with food. Again, we see some of the same side effects emerging, so headache, lactic acidosis is also of concern here. This tends to be the preferred agent for those patients who already have some renal dysfunction at the time of initiation of therapy. We'll present a bit of data later on in the talk to suggest that if your patients have bone disease, osteopenia, osteoporosis, that perhaps they should be initiated on the TAF formulation of tenofovir as well, as there are improvements that are seen in bone health while patients are on that preparation. So this is a really nice summary slide that goes over the table, but differentiates those patients without cirrhosis versus those patients with compensated cirrhosis and decompensated cirrhosis. And I think the important take home from this table is that tenofovir and entecavir appear in the preferred column for each of these disease states. There's some other medications that are listed, including adefovir, lamivudine, talbivudine. These are alternative or non-preferred agents. So for most patients that you're going to see in the office who meet treatment guideline or treatment parameters, they would be initiated on one of these three medications. On the table, there's a mention of pegylated interferon. Again, this is for younger patients without cirrhosis who may want a finite period of treatment. So, Dr. Madison, as with any chronic disease, chronic hepatitis B doesn't exist in a vacuum. Let's shift gears to talk about comorbid conditions that may impact treatment decisions.
Absolutely. And just as a friendly reminder for those great charts that you had earlier, these slides are available for download for your reference, because that's some really amazing information that you just shared. So when we take a look at the impact of medical comorbidities in our patient population with chronic hepatitis B, current estimates suggest that only a third of chronic hepatitis B affected persons in the U.S. are aware of their diagnosis, and only a fraction are likely to have be in care and in treatment for early stages of their disease. And as a result of often delayed diagnosis and treatment, patients with chronic hepatitis B virus are presenting at an older age and are more likely to have liver and non-liver comorbidities that can further complicate their treatment course. So we take a look at this particular graphic. As we can see from the graph below, this is comprised of both commercial insurance and Medicare patients. And when we look at this, we see that we are overwhelmingly getting more chronic medical conditions as people are progressing through their disease state. It includes things like cardiovascular disease, diabetes, hyperlipidemia, hypertension, as well as renal impairment, which we know those with chronic liver disease often end up having some semblance of, hepatorenal failure.
Also, I thought that the study was interesting in that there was an increase in comorbidities over the age range of the patients who were included.
Absolutely, I completely agree.
So, Dr. Madison, how prevalent is osteoporosis and chronic hepatitis B?
Well, if we take a look at this particular graphic, we can see that over time, we're actually seeing a lot more patients, especially those who are not maybe getting as advanced care or maybe not going in for chronic checkups. For our Medicaid population, maybe they're not accessing the healthcare system as frequently. We are seeing that a lot of those patients are progressing to osteopenia and osteoporosis and potentially leading to a fracture. So that's what we're trying to avoid. And obviously, having chronic liver disease itself potentially could be a risk factor for poor bone health. But then when you put on top of that some of our treatment modalities, that may be also predisposing them to bone health issues. So we are seeing a rise in our osteopenic, osteoporotic, and fracture risk associated with chronic liver disease associated with hepatitis B viral infection. We are also seeing instances where individuals are having challenges with chronic kidney disease as well, which we did know is the case for those with chronic liver disease. And so, again, very similar to the previous graphic, maybe a little bit more on par with both our commercial and our Medicare patients combined, seeing that over time, we are seeing more chronic kidney disease. But for sure, for our Medicaid patient population, which may have other chronic medical conditions that may be contributing to this, we are seeing a rise in chronic kidney disease, which may mean that we will choose a different treatment that may be less impactful on both their bone and kidney health. So when we take a look at possibly switching from a drug that may cause more issues with bone and renal health to one that causes less issues with bone and renal health. And again, not to go into the weeds, but when we look at these drugs kind of on a pharmacokinetic basis, you see that tenofovir disoproxil fumarate, or TDF, there's more of the drug that gets into the periphery versus those target tissues, versus when we look at TAF, you have less drug needed to get into the correct space and to impact that viral load, and therefore you have less of an impact on some of those peripheral tissues, which include our bone and our renal health. So again, when we look at the switch data here, in particular looking at both hip and spine, you see that we do have a pretty marked improvement when we switch from the TDF to the TAF medication. And this was at week 96 when we're looking at the potential risk for hip and spine fracture.
For the audience, this data comes from a study that was presented in 2020 looking at patients with hepatitis B, chronic hepatitis B infection. Some patients came into the study and were switched from TDF to TAF. Other patients remained on TDF for the duration of 96 weeks. And as Dr. Madison was saying, there was an improvement in bone mineral density in those patients who actually switched from the TDF preparation to the TAF preparation. We also see an impact on renal parameters during the course of this study. So if you look at creatinine clearance, there was an improvement in creatinine clearance in those patients who switched from the TDF preparation to the TAF preparation of tenofovir, and in other parameters of kidney function. So this is beta-2 microglobulin. So this is great data now that we have here to suggest that TDF and TAF are non-inferior. So as far as viral outcomes were concerned, they were pretty comparable, but TAF really having a favorable impact on bone health and kidney health in the context of this study. So Dr. Madison, the pharmacist sees the patient much more frequently than the physician. Thinking about a patient on antiviral treatment, what are some counseling and teaching opportunities that pharmacists can take advantage of when seeing patients when they come in for their refills?
Absolutely. I completely agree with you. During our current pandemic, we have realized the importance of the accessibility of a pharmacist with, over 80% of all adults being within 5 miles of a pharmacy. So I completely agree with you. And so with that being said, there are some things that we can help with because of those frequent visits for refills. And then also if the patient isn't coming on time for their refills, trying to decide, what can we do to help them with some of those adherence challenges? So the number one thing I would say that we can help with as pharmacists is the drug-drug interactions, especially when it relates to things that patients can get in the self-care aisle, right? So those OTC medications and supplements that they don't really consider to be medications can oftentimes interfere with our hepatitis B treatment modalities. And so some of the bigger culprits here will be things like milk thistle, some of the liver supplements, creatine supplements. Those are the things that, the patient thinks, innocently aren't going to cause any challenges, but really they don't understand that anything that you put in your mouth on a regular basis and into your body could potentially, cause interactions with your current treatment therapies. And so we also want to make sure that we're partnering with other healthcare teams to optimize our treatment of our patients. Because again, we don't do these things in a silo or in a vacuum, right? We're all doing this together, and it's that team-based interdisciplinary care that really helps to make sure that the patient is getting what they need and the most optimal patient care we can provide. So we also want to have that opportunity to discuss things like alcohol and substance use with our patients, which can be a difficult conversation, but we do want to make sure that we are having that open and honest discussion because these are things that they may not be discussing in the doctor's office. Oftentimes, some of these medications require prior authorization, and so navigating that insurance challenges sometimes is definitely something that the pharmacist can play an important role in, as well as helping patients to understand what's on the medication label. So providing them with education about any food requirements that may be part of the directions that their medication has, and then any safety concerns that they may be thinking about or have questions about. Ultimately, we want to address any of the questions that may not have been able to be addressed during their primary care visit or their visit with their provider, because, we know your time is limited, and we want to make sure that all of their questions are answered. As well as the issue with adherence, which I brought up earlier. So if they aren't coming back for that 30-day refill on time, really talking with them about what things are going on in their life that may be causing them to have challenges with taking their medication as directed. And then last but not least, recognizing that there are social determinants of health that may impact treatment and adherence, which include things like transportation, perceived, systemic biases or inherent, challenges because of their race, their gender, or their ethnicity. All of these things combined impact their ability to potentially get to the pharmacy and to get their medications on time.
This has been a great discussion, Dr. Madison. So before we head into questions, let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. This is what we hope that our audience will take away from this presentation to apply to their clinical practice. The first of which is to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that might interact with their hepatitis B antiviral treatment. And lastly, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plan to optimize outcomes. Dr. Madison, with that, I think it's time for us to let our audience join the conversation and ask some questions.
I can't wait.
Well, good evening. We already have a number of questions in the chat box, so let's dive in. So I'll pose this first question to Dr. Madison. The question is, you mentioned the current estimates suggest only a third of chronic hepatitis B affected patients in the US are aware of their diagnosis, and only a fraction are linked to care and treated at early stages of disease. How can we as pharmacists be better equipped? And what can we do to better link patients to care and support them to get earlier therapeutic treatment?
Well, first and foremost, I think that's an excellent question. I think that anytime we're looking at a population that may or may not know a diagnosis, providing them with access points to care is a huge benefit. And so the first thing that I would say is looking at some of those community partners that may be able to allow for additional testing. So one of the things that we did when I used to be at the health department is that we partnered with an organization called Hep B Free Las Vegas. So I currently live and practice in Las Vegas, Nevada. And so there are these Hep B Free organizations all over the country. And they were targeting the biggest at-risk population, which we know is the AAPI community. And so we would do testing and we would do vaccinations at, community centers and Buddhist temples. And we would go to our Asian community centers. And so I think doing those kinds of things are really helpful. And so if your pharmacy is located in an area that services a larger AAPI community, I think that that's a great place to start looking at partnering with some of those organizations, as well as partnering with the health department. They are a great partner. I think they're always looking for community engagement. And if the pharmacy is looking to host some of those kinds of events, I think that would be a great way for you to be able to screen some people that maybe ordinarily wouldn't have been screened and potentially could pick up some of those unknown diagnoses.
I was going to add as well that I think information is power, and someone wrote in the chat about patient resources. There are various places that you can go to get patient resources. hepb.org, so the Hepatitis B Foundation is one of those. CME Outfitters has some information as well. So a plug for the program. You can certainly find things on up to date. But a lot of various organizations, like the one that Dr. Madison was referencing, they also have information for patients. So I think that would be a wonderful connection to make. Also, some of these programs will provide medications for patients who aren't able to afford them. They will do follow-up testing to determine when they should be treated, if they should be treated. And so I think that partnering or at least finding the organizations in your particular geographic area where you practice is perhaps one of the best ways to help link hepatitis B patients to care.
Yeah, the one other thing. Oh, sorry. I was just going to also
go ahead,
mention. Yeah, so with that community, it's always good if you can provide information in language. And,
right.
We know, especially for vaccine information, you can go to immunize.org, and all of those vaccine information statements are all in a variety of different languages, including languages like Tagalog, Vietnamese, Mandarin. Chinese, Mandarin, they're all, and that's a big thing. And so when we partnered with them, the biggest thing that we were able to provide is my pharmacy students who spoke language. And so, if you have somebody who's in your pharmacy who speaks the language, I think that bridge is so important. And even if it's just you providing information about getting tested, that probably is single most important intervention beyond just you actually physically being able to provide the testing. So just wanted to make a plug for making sure that we're providing in-language services for our non-native English speakers.
So there was a question that also popped up in the chat about non-adherence and pharmacists really bearing witness to non-adherence to the treatment medications that we utilize for hepatitis B infection. So how can pharmacists best support our patients and also help them to understand the long-term benefits and also potential side effects of therapy? So I'll let you go ahead first, Dr. Madison, and then I'll share some thoughts.
Absolutely. So, as I mentioned during the program, I think finding out what's going on in people's lives, right? So, there are many reasons why someone may or may not be able to take their medications. If it's causing them stomach upset and they're dealing with food insecurity, that might be a reason why they may not be taking their medication. It's also potentially a financial strain. So, there's also that. And then just understanding, their lifestyle. So, do they work shift work job where they forget to take their medication because their schedule's always changing and there's no consistency. So, really helping them to make it a part of their routine, and then ultimately talking with them about what their goals for therapy are. Because at this point, we're really trying to stop progression of disease and, further deterioration of the liver and progression to fibrosis and cirrhosis. And so with that, and if they know what their goal of therapy is, if they know where they start, because obviously, we wouldn't put them on medication unless it was absolutely necessary, because we wait to start until it really is needed. I think having that open and honest dialogue with the patient and really finding out what barriers to care they may have will help them with that adherence factor. And obviously, because pharmacists are one of the most accessible healthcare professionals, I think we can take the time to really get to know the patient and understand what their challenges are and try to address those as much as possible. And potentially may even need to involve, case management or possibly looking at some patient assistance programs through, manufacturers that make the medications that we use for hepatitis B.
I was going to add that I would be lost without my pharmacy staff. They often provide me with all of the information that I may or may not have obtained from the patient when they see me in the office. Food insecurity, whether it has to do with affording their medications, they have to pay for other medications that are just as important, say their cardiac medications. And so copays are very high and perhaps prohibitive. So if I didn't have the information of my pharmacy staff, I really wouldn't be able to appropriately treat patients. I value that input so much. And really, I have to tell you that when patients are not taking their medications, there's often something else. There's some other reason why they're not able to do that. So certainly not moving to judgment about their ability to adhere to the medication, but really delving into what are the reasons why and trying to provide some solutions there around that. There's a question that just came up in the chat about the relative cost of TDF versus TAF. And I'm not sure about the actual details about cost. Obviously, TAF is going to be more expensive than TDF. And often I get a lot of resistance from insurance companies regarding getting patients on the TAF preparation of tenofovir. And so usually there are certain benchmarks, whether it has to deal with their renal function or having some other issue on TDF. That's usually the circumstance under which I'm able to obtain the TAF preparation of tenofovir. There was also a question about the tolerability of these oral medications. So are they difficult to swallow? Are there differences in sizes of the pills, and would that change my recommendation? So I'll let Dr. Madison go at this question. I don't know specifically about the sizes and how they vary versus, tenofovir, TDF, and the TAF preparation of tenofovir.
Yeah, so it's slightly smaller. It's not significantly smaller, but we have had some patients who have reported that the ease of swallowing was a little bit easier with the TAF agent because the size of the pill is a little bit smaller. And so again, it's really based on, because now we've got a generic, and so there's that. So we're having to put that into the mix now too. And so I agree. I think, it's unfortunate because, we end up having to do a stepwise approach. And, there are some patients that you just automatically know that they would benefit more from the TAF formulation than the TDF, but you just got to go through those hoops with the insurance company. And so there's a couple of things that we've used at our clinic to try to help them navigate that process. So the first is if they are, having some GI side effects, then we can sometimes talk about the, potential for having some GI issues more so with the TDF versus the TAF. We also obviously have the renal issue and then the bone health issue. And so if they're already osteopenic or osteoporotic, we can usually get the TAF component approved right away. And then same thing with the renal function. If they're between like 50 to 30, we can usually get them approved right away. If it's anything less than 50, then we can usually get it approved. If they're between like 60, 70, around there, then it's a little harder, just because, the individual component, you can dose adjust down to 50, but obviously if their renal function is being impacted that much, we probably should just go ahead and use the TAF component.
So, Dr. Madison, you had mentioned something about making a decision about treatment and how difficult that decision is. So I just wanted to expand upon that because there are actually a few questions in the chat specifically relating to that. So in my personal practice, I think very hard about whether I should start a patient on treatment for hepatitis B infection. Because we are not treating the virus, we're essentially suppressing viral replication. Most patients will stay on therapy indefinitely. So I don't take this decision lightly, and I certainly will follow patients. They might have multiple blood draws before you determine that they need to be on therapy. If somebody has cirrhosis, for me, that's less of a decision. We're going to put them on therapy. If somebody does not have cirrhosis, then we're going to look at the ALT to see if that is in normal range. If it's elevated, we're also going to be checking the Hep B DNA, and that will help to inform the decision. And then in addition, we'll check the hepatitis B E antigen. Now, there are some more simplified approaches to how we evaluate patients with chronic hepatitis B infection. The approach that I utilize is the one from AASLD. But again, because it's so kind of complicated in clinical practice, we're trying to simplify those recommendations. And so we used to not only check the surface antigen, we would check the hepatitis B E antigen, and then we would check the DNA. And if it was somebody with hepatitis E antigen positive, high levels of viremia, so greater than 20,000 international units, and an elevated ALT, then that's somebody you would consider treating if they had persistent elevation of the ALT and the hepatitis B DNA. If it's somebody who had a hepatitis B E antigen negative state, and then they had a viral load greater than 2,000, ALT greater than 2 times the upper limit of normal, then again, that's somebody you would consider treating, but you would want to make sure that that's a state that was persistent, not that they were then able to clear the virus or have a very low level of viremia. So before I even start, I'm following the patients serially, and then I make the determination of whether they need therapy. Now, there are some endpoints. Some are easier to manage than others. So for instance, if a woman came to me during pregnancy, she had a high viral load, so a high hepatitis B DNA over 200,000 international units. Going into the third trimester, I would treat her to decrease her viral load and to decrease the likelihood of mother-to-child transmission. But that's somebody that I would subsequently wean off of therapy in the postpartum period. The other patient I would think about taking off of therapy is somebody who is non-cirrhotic, they have a normal ALT, and they have seroconverted, meaning that rather than having surface antigen positivity, they now have surface antibodies. So that surface antigen becomes negative. So that's also somebody that I would think about withdrawing therapy on. The other things, the other potential endpoints are difficult to decide upon, and would really take some consideration and sometimes even a liver biopsy to see if people are having any ongoing inflammation or have evidence of advanced hepatic fibrosis. So before I even start the process of thinking about therapy, I'm actually monitoring the patient serially. There was another question in the chat about how often we would obtain abdominal ultrasound, liver ultrasound on patients with chronic hepatitis B infection. And some of it has to do with country of origin and the relative risk of developing hepatocellular carcinoma. Because hepatitis B intercalates into the DNA, it is in and of itself a carcinogen. So even if patients don't have evidence of cirrhosis, they can develop hepatocellular carcinoma. So the recommendations currently in place suggest screening of patients. So Asian males starting at age 40, Asian females starting at age 50. The same is true for patients of African origin. Obviously, if patients have cirrhosis, you're also screening for HCC, and that's usually every 6 months with abdominal ultrasound plus minus alpha fetoprotein. I don't know if you have any other comments, Dr. Madison, but that's essentially how careful I am with starting patients on medications, because again, these medicines are likely to be lifelong.
Right, because ultimately there's no cure. Really, we want to focus on prevention and then harm reduction strategies, talking with them about lifestyle modifications if they're currently drinking or engaging in illicit drug use, and those things like using tools like the Audit C or the Audit 10 to really look at the alcohol dependency and how that could impact their overall liver function. I think that's something that we don't often do at the pharmacy setting. And then just looking at like what really is a standard drink. And so, I live here in Vegas and people like to go party. And it was interesting to me when we started screening our patients using the Audit C tool, how many people didn't actually know how much a standard drink was. And a lot of times people will tell you maybe 1 or 2 glasses, but when you look at what a standard drink is, you are typically overserved at a restaurant, right? And so, is that a 6-ounce pour? Is that a 9-ounce pour? So talking with patients about like lifestyle, I think is really important as well. And really looking at it from a standpoint of like, this is not from a place of judgment. This is just really coming from a place of overall health and wellness. And then I'm not sure if you, I feel like maybe if people aren't as familiar with that hepatitis E, that's really more indicative of active replicating infection, and that really means that they're infectious. And so that is also part of the consideration. Although we know that if you're exposed as an adult, your risk of developing chronic infection is low, the risk is still there. And so we do want people to understand that if that is the case, that we want to reduce their risk for transmission, because this is a communicable disease.
So speaking to that point, Dr. Madison, I just wanted to know if you had thoughts about the administration of hepatitis B vaccine and COVID-19 vaccine, and if there are any thoughts about precautions, certainly with respect to transmission of hepatitis B infection.
Yeah, absolutely. So, we've been, as a country, we've administered millions and millions of doses. And so we know that, the possibility of needle sticks are there. And so there is this, potential risk for exposure to hepatitis B virus just from having a needle stick or a needle injury with all of the vaccinations that we're providing. And so it's just more of a precaution, and just really looking at those those pandemic recommendations about, wearing gloves and how we're handling our syringes. And, obviously we're making sure that those doses as much as possible aren't wasted. But when we're hurrying and we're rushing, things can happen and accidents can happen. And so just obviously really making sure that people are aware of where that needle is and always using the safety device. I know there was, some of the ancillary kits that came with the vaccine. Some of them were not the best needles that we like to use, that are like the safety glide or, some of those vanishing point syringes. And so I think sometimes people were having a little bit of challenges with those safety devices. And so always make sure that you know how to deploy the safety device per OSHA before you use the needle that's provided to you. And that really will help with reducing the possibility for needle sticks and obviously reduce your potential risk for exposure to hepatitis B virus.
Great. And any thoughts about co-administration and CDC recommendations recently?
Yeah, I mean, that's kind of hot off the presses, right? And so when ACIP went back and reviewed the data for adolescents when they were looking at the expanded EUA status for Pfizer, they really wanted to make sure that there were no additional barriers to adolescents receiving all of their needed vaccinations. And so at that point, it was really being seen as in an abundance of caution to have that 14-day window. We do co-administration of vaccinations all day, every day, right? And so I think we weren't sure because this was a novel vaccine type with the messenger RNA product. We've had the, modified adenovirus in the past with things like, Ebola and Zika, but this was new for us. And so it was really just in an abundance of caution. And so I'm really glad that ACIP was astute enough to realize that, taking away that recommendation and that need for 14 days in between COVID vaccines and other vaccinations, I think was really prudent, especially now as we see, our supply outstripping our demand. And so we don't want there to be any other reason why people don't want to get their COVID vaccine. And if it means that that's delaying their other recommended and routine vaccinations, that might be another reason why they may not get vaccinated. So again, co-administration at this point is considered to be okay. And that's not just for adolescents, that's for adults as well.
Great. So just a few more questions, one or two more questions. One was about partnering with patients and their healthcare providers to help improve sort of adherence, but also monitoring for bone health and kidney health, and whether restrictions have been placed around that. So for instance, for some post-transplant medications, we'll ask that patients have updated laboratory studies before they're dispensed. So I don't know if your pharmacy or your pharmacy practice puts any parameters around that, Dr. Madison, and whether you think that would be helpful.
Yeah, I mean, I think obviously that could be within an abundance of caution. Obviously, we don't want to start people, post-transplant on anything that's, going to worsen their renal function, and so, or their liver function for that matter. And so, I think that's definitely a subspecialty within pharmacy. Obviously, transplant. There's a lot of transplant pharmacists out there that could probably answer this better. But I do think that, anytime, we can get another monitoring parameter in there that can help us to make a more informed decision for the patient, I don't think that it's harmful. I think that that's just another tool in our toolbox that we can use to evaluate the patient.
Great. So unfortunately, that brings us to the end of our time today. We've had many great questions. I'm sorry we're not able to answer them all, but before we go, let me remind you of the key points or SMART goals for our program. They are to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that may interact with their hepatitis B antiviral treatment, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plans and how to optimize those outcomes. So I want to thank you, our audience, for all of the great questions you sent in. If any of your colleagues missed today's program, let them know that there's another live credit opportunity available on Thursday, June 24th at 7 p.m. Eastern Time. For additional clinician and patient resources, please visit CMEO Pharmacist Central at cmeoutfitters.com. Stay safe, and thank you again for participating and providing the best care for our patients. Thank you.
Thank you again for joining us tonight. Bye-bye.